I would like to welcome you all to this ICH webinar. And the title is HTLV related malignancies. Where do we stand? And our distinguished speaker today is really a top expert in the field, namely Dr. Shigeo Fuji. I hope I'm pronouncing it correctly, who is the Vice Chief Clinical Director of the Department of Hematology at the Osaka International Cancer Institute in the city of Osaka in Japan. He actually completed his residency in internal medicine at the Osaka University Hospital, then had actually a fellowship in hematopoietic cell transplantation at the National Cancer Center Hospital in Tokyo. He also actually did some research and postdoc work in Würzburg in Germany for 2.5 years. He returned back to Tokyo in Japan, and currently, as I mentioned, he is the Vice Chief Clinical Director at the Osaka International Cancer Center Hospital. And the topic today is an extremely important one because it truly represents a public health issue in many areas on the globe, for instance, like in Japan, but also in many places in Southeast Asia, but also Africa. And we are very fortunate having Dr. Shigeo Fuji because he is actually the expert who was the co-first author of the consensus report about management of adult T-cell leukemia lymphoma, which was published, as you may remember, in the Journal of Clinical Oncology in 2019. So this is a live webinar. It's interactive, so please do not hesitate to send your questions, your comments, your suggestions. And at the end of the webinar, we will have a few minutes for Q&A and discussion with Dr. Fuji. So, Dr. Fuji, thank you for joining us today. I know it has been a very busy day for you, but still we are very grateful, and I would like to invite you to the podium. Please share your slides and we will reconvene after your talk. Thank you for joining.
It is a great pleasure and honor to have an opportunity to talk in ISCH webinar today. Today I'd like to talk about HTLV-related malignancies, namely adult T-cell leukemia lymphoma. This is my COI. At first, I briefly touch on the background information relating to HTV1 and move on to the first-line conventional chemotherapy followed by upfront allogeneic transplantation. And after that, I will briefly talk about salvage chemotherapy in relapsed refractory ATL. And finally, I'd like to talk about other topics, mostly current issues relating to HTV1-related malignancies. As Professor Moti mentioned, HTV1 carriers are observed in worldwide. So Japan is famous as an endemic area of HTV1 infection, but as you can see, we have many H1 carriers in Africa and South America, and in some developed countries such as North America and Europe. There are lots of immigrants from Africa or South America, so it is expected that the number of patients with HIV-related diseases are increasing in the near future. This figure shows a mechanism of development of H1 related malignancies. Uh, Once H1 infected T cells in the body, it persists in the body for decades. And in a part of H1 carriers, it progresses to ATL. And as you can see, at first, H1 infected cells are polyclonal, but once it progresses to ATL, it becomes oligoclonal or monoclonal. In blood smears of ATL patients, you can find some abnormal lymphocytes, as you can see here. So there are lots of typical abnormal T cells of ATL patients here. But in some cases, the abnormality is mild, as you can see in the bottom of this slide. So uh, you have to be careful whether patients really have ATL or not using microscope. And also, in expected cases with ATL, it is recommended to use multicolor flow cytometry. This table shows criteria of clinical subtypes of ATL. Um, in general, we use Shimoyama criteria for the diagnosis of ATL patients. So, in indolent type of ATL, it includes smoldering ATL and chronic ATL. And in aggressive type ATLs, it includes lymphoma type and acute type. We use the number of lymphocytes and the percentage of abnormal T lymphocytes and level of LDH uh, for the classification of clinical subtypes of ATL. This figure shows overall survival according to the clinical subtype of ATL. In aggressive type ATL, the clinical outcome was dismal, with median survival less than 1 year, and long-term survival is rare. So 5 year overall survival was less than 20% in most clinical studies. And in terms of indolent ATL, the long-term overall survival was not satisfactory. So as you can see, in most cases, they progresses to aggressive type, and in 5 years, the overall survival was around 50% in smoldering ATL and around 30% in chronic type ATL. Now, I'd like to move on to the first-line chemotherapy followed by upfront allogeneic transplantation. In NCCN guidelines, it is recommended to use systemic chemotherapy in acute or lymphoma subtype, and Digoxin and interferon alpha can be also used in acute type ATL. Unfortunately, AZT interferon alpha is not available in Japan, but it can be used in Europe or in the United States. After we achieve complete remission or partial remission, we can conduct upfront allogeneic transplantation in patients with aggressive ATL. At first, I'd like to focus on this part, conventional chemotherapy. In Japan, we tried to improve the clinical outcome using various kinds of chemotherapy regimens. But unfortunately, as you can see, irrespective of the type of chemotherapy regimen, the overall survival did not differ. So as you can see, median overall survival was less than 1 year, and long-term survival was rare using chemotherapy alone. The best chemotherapy regimen in Japan is VCAP AMP VECP, so-called LCD-15 regimen in Japan. And we conducted a randomized control trial comparing VCAP AMP VCP regimen versus biweekly CHOP. And the difference was not so huge, but the overall survival with VCAP AMP VCP was slightly better than CHOP in this prospective studies. Therefore, this regimen is commonly used in Japan in patients with aggressive ATL. We recently assessed the superiority of this regimen compared with CHOP regimen using a large data set of our group. And we uh, found that LC15, this Japanese regimen, was superior to CHOP regimen. But as you can see, the difference was not so huge, so around 5%. This figure shows the promising result using interferon alpha plus rhodopsin in patients with ATL. Uh, it was reported in 1995, and in this study, not many patients were enrolled, but in this patients cohort, around 50% of patients achieved complete or partial remission. And it seems that short-term clinical outcome was favorable, although long-term survival was rare in this study. After that, this regimen was often used in Europe or in the United States, and Dr. Bazarbace reported that this antiviral therapy was effective in patients with acute type ATL. As you can see on the left-hand side, antiviral therapy was superior to compared to conventional chemotherapy. But this regimen did not work well in lymphoma type. Therefore, in patients with lymphoma type ATL, conventional chemotherapy is still recommended. So in NCCH guidelines, various kinds of chemotherapy regimens are recommended, so such as dozadacide epoch and BV plus CHP and rhodopsin plus interferon alpha, etc. Um, as far as I know, data using brentuximab vedotin plus CHP in patients with ATL is quite limited, but it is reasonable to use in patients with CD30 positive ATL patients. This report is the clinical outcome of HTLV-related ATL in the United States. In this study, they included around 200 cases with ATL, and unfortunately, only 5 patients received allogeneic transplantation in this cohort. And in this study, 2/3 of patients received conventional chemotherapy, and 1/3 of patients received antiviral therapy. And in terms of the overall response rate, the response rate was a little bit better using chemotherapy than antiviral therapy, but antiviral therapy worked well in patients with acute type ATL, as reported beforehand. As only 5 patients received allogeneic transplantation, the overall survival in this cohort was not satisfactory. So overall survival was uh, poor in long term in acute type ATL and lymphoma type ATL in this cohort. So what is a major issue in the chemotherapy for patients with ATL? So this table shows clinical outcome using various kinds of chemotherapy regimens in Japan. As you can see here, um, in most clinical trials, the response rate was not so bad, so it can be from 50% to 80%. However, median survival time was usually less than 1 year in most studies. It means that chemotherapy drugs works well for a short period of time, but it progresses soon after that. It is the same in the report from the United States. This table was shown a few minutes ago. As you can see, the response rate was favorable in using chemotherapy. So around 70 to 80% of patients achieved objective response, and around 50% of patients achieved objective response using antiviral therapy. Uh, so this figure shows cumulative incidence of relapse or progression using chemotherapy. So in this figure, as you can see, irrespective of the risk of ATL, most patients suffered from progression less than 1 year, mostly less than 6 months. Therefore, it is difficult to achieve long disease control using conventional chemotherapy. And in addition, it is difficult to continue the chemotherapy in patients with ATL. This is a prospective random study comparing these two regimens, and the rate of completion of the planned treatment was only 32% in the VCAP-MP VCP arm and 49% in the CHOP arm. So it was significantly lower than CHOP regimen in, for instance, B-cell lymphomas. And it can be due to the disease progression, but also due to the toxicity. And as you know, patients with ATL are at high risk for opportunistic infections such as cytomegalovirus or PCP. So this is a case of aggressive ATL with a concomitant PCP at diagnosis. In such cases, we have to start chemotherapy. At the same time, we have to treat PCP. Therefore, the chemotherapy regimen is really complicated, especially when patients have CMV disease. We have to start ganciclovir, and it can cause myelosuppression. So it is really difficult to handle in these high-risk patients. Now I'd like to move on to the upfront allogeneic transplantation in chemosensitive disease patients. We have a long history of allogeneic transplantation in patients with ATL. Dr. Utsunomiya reported a promising result of allogeneic transplantation in patients with acute or lymphoma type ATL. So in this study, the age was rather young, but as you can see, around 50% of patients had more than 2 years overall survival. It was favorable considering the high risk of uh, mortality in patients with aggressive type ATL. After that, we also tested the effectiveness of reduced intensity conditioning regimen in patients with ATL. As you can see, in this regimen, using fludarabine plus busulfan-based conditioning regimen, around 30% of patients achieved long-term overall survival. It was, of course, favorable considering the high risk of disease. After that, in Japan, we usually perform allogeneic transplantation in chemosensitive ATL patients. So as you can see, using Japanese registry database, and the clinical outcome was favorable when patients received HLA matched related or HLA matched unrelated donor transplant. So in revised ATL International Consensus Meeting report, allogeneic transplantation as consolidation is recommended. So as you know, it is obvious that chemotherapy regimen alone are suboptimal for the majority of patients with ATL. Therefore, we do not have any prospective randomized trials that demonstrated the clinical benefit of upfront allogeneic transplantation. It is reasonable to recommend allogeneic transplantation as consolidation in patients with aggressive ATL. So now we would like to show you some recent data in patients with ATL. So our team performed a prospective one-arm study using haploidentical transplantation in patients with ATL. In that setting, we used fludarabine plus melphalan and low-dose total body irradiation. And as GVHD prophylaxis, we used, of course, PTCY in combination with tacrolimus plus MMF. We have already published preliminary data in TCT in 2 years ago. And in this report, we enrolled 18 patients with aggressive type ATL. And most of them had chemosensitive disease at transplantation. As you can see, the short-term clinical outcome was really promising. So more than 80% of patients achieved 1 year overall survival in this clinical trial. And the incidence of severe acute GVHD was reasonably low, around 10%. And the risk of severe chronic GVHD was rather high in this study. I don't know why, but as I showed you, the overall clinical outcome was favorable. So recently, we use haploidentical transplant with PTCY often in patients with acute type ATL. I'd like to introduce some reports outside of Japan. And this is a single center retrospective analysis from New York. And in this study, 100 patients were included and 17 patients received allogeneic transplantation. And in this case series, 35% of patients received haploidentical transplantation. And as you can see, in patients who received allogeneic transplantation, the clinical outcome was really promising, and around 40% of patients achieved long-term survival. And especially in patients who received allogeneic transplantation in CR1, the clinical outcome was promising in this data set. And there is also a report from France, and in this report, 53 patients were treated between 2016 and 2023, and 23 of them received allogeneic transplantation. And more than half of patients received haploidentical transplantation in this data set. And they observed significantly improved survival in recent cohorts, as you can see here, so shown in red. And it was far better than the historical control shown as blue here. And the major difference was the number of patients who received allogeneic transplantation. So only 5% of patients received allogeneic transplantation in the historical control, and around 40% of patients received allogeneic transplantation in the recent cohort. And the outcome in patients who received allogeneic transplantation was really good in this case, in this cohort. So around 70% of patients achieved long-term progression-free survival in this cohort. Therefore, it is reasonable, in my opinion, to recommend early upfront allogeneic transplantation for all transplant-eligible patients nowadays using any kind of stem cell sources, including haploidentical transplantation. And I think allogeneic transplantation is still a backbone of the treatment of strategy in patients with ATL, but we can improve the disease control using novel agents before or after allogeneic transplantation, as in other diseases such as FLT3 ITD, mutated AML, or Ph positive ALL. Now I'd like to move on to the salvage treatment in relapsed refractory ATL. As expected, the clinical outcome in patients with relapsed refractory ATL was dismal. It was rare to achieve long-term survival. There are some options in patients with relapsed refractory diseases such as mogamulizumab or other novel agents, or directly conduct allogeneic transplantation. But as you can see here, when we directly perform allogeneic transplantation in progressive disease, the clinical outcome was dismal, so it is not an clever idea. And now we have several options of novel agents such as mogamulizumab, anti-CCR4 antibody, and brentuximab vedotin, CD30 antibody, and tsushignostat HDAC inhibitor, or valemetostat EZH1/2 inhibitors. At first, I'd like to talk about mogamulizumab anti-CCR4 antibody. It is possible to achieve objective response using anti-CCR4 antibody, but long-term disease control is really difficult using this drug. As you can see, in long-term follow-up, it is quite rare that we achieve long-term disease control using mogamulizumab. And in addition, when we use mogamulizumab in transplant-eligible patients, we have to be careful about the risk of severe acute GVHD after transplantation. In this retrospective study, we found that patients who received mogamulizumab before transplantation had higher risk of non-relapse mortality compared with those who did not. And there was no difference in the risk of relapse or progression. Collectively, the overall survival was inferior in patients who received mogamulizumab before allogeneic transplantation. The main reason can be the increased risk of acute GVHD, especially severe steroid refractory acute GVHD. So as you can see here, the risk of severe acute GVHD was around twice in patients who received mogamulizumab before transplantation. Especially when we use mogamulizumab less than 50 days before allogeneic transplantation, the risk of non-relapse mortality was unacceptably high. So around 60% of patients had non-relapse mortality after allogeneic transplantation when patients received mogamulizumab less than 50 days before allogeneic transplantation. It is a huge problem. Why such a phenomenon can occur? So it can be because CCR4 is expressed in regulatory T cells. As you know, the balance between effector T cells and regulatory T cells is important after transplantation. And when mogamulizumab depletes regulatory T cells, it can increase the risk of graft versus host disease, and it can lead to higher NRM and poor overall survival. Therefore, it is recommended not to use mogamulizumab before allogeneic transplantation, and when it is used, it is better to wait for a while to perform allogeneic transplantation. But we are not sure whether 50 days is sufficient to mitigate the risk of severe acute GVHD. We need more data to confirm this recommendation. And we would like to introduce some data relating to parimetostat EZH12 inhibitors. In this prospective study, we enrolled 25 patients with relapsed refractory ATL, and none of them received allogeneic transplantation beforehand. And in this study, uh, around 50% of patients achieved objective response. It was favorable considering we used only one a single agent, and it was highly effective in patients with disease in peripheral blood. It was common in acute type ATL, so it can be a good option in patients with acute type ATL. And the toxicity was tolerable in most cases. The most common treatment-associated adverse effects were myelosuppression. So in patients with severe myelosuppression, we can use GCSF or transfusion to mitigate the adverse effects. And we do not have a long-term result using this agent, but it seems that in some patients, we can achieve long-term disease control using single-agent parimetostat. So we wait for the long-term clinical outcome using this agent. And we also have lenalidomide or tocilizumab, but these agents can work in a part of patients, but it is often difficult to achieve long-term disease control using these agents. So finally, I'd like to talk about other topics, mainly the problems in patients with ATL. So at first, we do not have an established treatment options in patients with indolent ATL. So AZT interferon alpha is not available in Japan, and in most cases with indolent ATL, it progresses gradually, and long-term survival was really poor in patients with indolent ATL. It is a huge problem in patients with indolent ATL. And another topic is the increase of ATL patients in non-endemic areas. So Osaka is not a typical endemic area of ATL, but as you can see here, in cancer registry of Osaka shows that there is a steady increase of ATL patients in Osaka, and the overall survival was really poor in Osaka. So maybe the diagnosis of ATL could be delayed in non-endemic areas because nobody knows ATL can occur in Osaka as well. So we have to change the treatment strategy in non-endemic areas. And in some really high-risk patients with ATL, allogeneic transplantation does not work well. So in this figure, um, only around 20% of patients achieve long-term disease control even when they receive the allogeneic transplantation. So it is unsatisfactory, of course. Therefore, we have to improve the clinical outcome of these very high-risk patients as well. So in conclusion, upfront allogeneic transplantation is an integral part of treatment strategy in patients with aggressive ATL. And chemotherapy regimen is effective in the majority of patients, but it is really hard to achieve a long-term disease control using conventional chemotherapy alone. So it is crucial to conduct upfront allogeneic transplantation at an early time point. And we still have many unresolved issues in the field of ATL. As I mentioned, there is no established treatment in patients with indolent ATL, and there is an increase of ATL patients in non-endemic areas, so in particularly metropolitan areas in developed countries. And it is also a problem that highly aggressive patients had a poor clinical outcome even when they receive allogeneic transplantation. To solve these problems, we need an international collaboration to develop novel treatment options or strategies in patients with ATL because the number of cases in each country is quite limited. I'd like to thank all the contributors of my studies, my colleagues from Osaka International Cancer Institute and my colleagues from National Cancer Center Hospital. And I'd like to also thank the member of ATL Working Group, Japanese Society of Transplant Cellular Therapy. And our institute was recently introduced in EBM TV. Thank you very much for your attention.
Thank you very much, Dr. Fuji, for really a fantastic and comprehensive overview, really cutting edge. I'm very grateful. So we have time for some questions, and we have received a lot of questions, so I'll try to structure them. One maybe naive question, I don't know, is there a way to prevent HTLV transmission?
Thank you for the question. So, in most cases, HB1 can be transmitted as vertical transmission, so from mother to child, and it is important to avoid breastfeeding. It can significantly reduce the risk of transmission in baby, but it's not 100%. So it's one way to reduce the risk of transmission.
Excellent. And I believe this is an important piece of information. Also, of course, in general, we do encourage breastfeeding for babies. I have another question here about apparently, I'm trying to summarize the question that most of the patients, if they are young and fit, should go to allo transplant. Are there a group of patients or maybe a minority of patients who, even if they are eligible, should not go to allo, maybe having a sort of a chronic indolent disease?
Yes, so in similar mass criteria, when patients have indolent ATL, so such as smoldering or chronic type ATL, yeah, it is reasonable to have watchful wait, as in indolent type B-cell lymphoma. But once progressed, it is really rapid. So it is important to carefully monitor patients, especially when patients have chronic type ATL.
Okay, wonderful. Another question about transplant techniques for these patients. One question is about the use of cord blood as a stem cell source, and whether this is something of interest or used. But also another question about the use of haplodonors and post-transplant cyclophosphamide. What is the current experience?
Thank you. So cord blood is commonly used in Japan, and cord blood is often used in patients with ATL as well. But in recent retrospective studies, the relapse rate is a major issue when patients receive cord blood in patients with acute type or lymphoma type ATL. And therefore, when we use cord blood transplant in patients with ATL, we usually choose cord blood only in patients with complete remission. And in other cases, we prefer to use haplo with PTCY.
Okay, superb. Well, I'll take another three questions because I believe they are important. Do the patient with HTLV-related malignancies have a higher risk of opportunistic infections with and without a transplant?
Yes. So patients with ATL can have CMV disease, for instance, even they do not receive urgent transplantation. So when we uh, treat patients using chemotherapy, we have to monitor CMV even when they do not receive transplantation. And after transplantation, of course, they are at high risk for CMV disease. So we routinely use letermovir in patients with ATL.
Excellent. Another question we have, and you mentioned, I think this, I believe, a couple of times. Why do you think we have more GVHD after using MOGA?
Thank you. And so probably it is because mogamulizumab deplete CCR4 positive regulatory T cells. And mogamulizumab is a humanized monoclonal antibody, so it persists for months in the body. So even when they received mogamulizumab before transplantation, it persists even after transplantation. So it continuously depletes donor-derived regulatory T cells. So, of course, it can lead to uh, severe acute GVHD and steroid refractory GVHD.
Wonderful. Thank you so much. Very clear answer. We still have 1 minute, so I'll take one question. What do you think about maintenance therapy after allotransplant, like with IMiDs or HDAC inhibitors or any other agents?
Oh, it's a very great question. So, we don't know the answer yet, but as you know, lenalidomide is difficult to handle after urgent transplantation, but maybe EZH1/2 inhibitor can be an option. In my experience, it does not cause the increased risk of GVHD, even they are used after transplantation, but we do not have much experience using parimetostat after urgent transplantation.
Excellent, fantastic. Thank you so much, Dr. Fuji. And I apologize, we'll not take more questions. It's exactly 45 minutes past the hour. So I would like to thank you all for being loyal to the ICH activities. Thank you for joining this webinar. Unusual timing for us, but I believe after this very successful experience, we will have more of these webinars in the middle of the day for European
Mhm.
countries, early evening for our colleagues in Asia. This is really fantastic. And thank you, Dr. Shigeo Fuji, for really a great effort summarizing state-of-the-art management and diagnosis when it comes to HTLV related malignancies. So for the time being, I'd like to say thank you, and wherever you are, please stay safe and keep well. Thank you very much.
Thank you very much.